This next section of notes is on the heart. So some general characteristics of the heart. The heart is approximately the size of a fist. It weighs less than 1 pound, which is approximately 250 to 300 grams. It is only slightly to the left of the midline. So it's only about 1.5 centimeters left of the mid-sagittal plane. So it is to the left, but just slightly. The heart does have the ability to beat even when disconnected from the body, as long as the heart has a blood supply going to it, nourishing the heart itself. It has the ability to beat on its own, even without nervous system control. On average, resting heart rate is approximately 72 beats per minute. That equals about 115,000 beats per day. But that changes and is affected by many different factors: pain, fever, stress, exercise, bleeding, blood pressure, medications. All of those can increase or decrease the resting heart rate. The entire volume of blood is pumped through the body about every minute. And so that would be about 2,000 gallons of blood per day that the heart is pumping. So heart gross anatomy, we have the pericardium, which is a double layered membrane that surrounds the heart. In between the two layers of the pericardium is the pericardial cavity. So that space is filled with fluid. And the job of that fluid is to reduce friction and to dissipate heat. Since the heart is a muscle, and we know muscles generate heat, that fluid helps to dissipate some of that heat. And also, since the heart is continually beating and very near to the lungs and other tissues, we want to make sure that we're not damaging surrounding tissues with all of that friction. The heart itself has 3 layers. The outer layer is the epicardium. That is the outer layer that's actually connected to the pericardium. The heart muscle itself is the middle layer called the myocardium. And the inner wall is the endocardium. And that is what lines the hollow chambers inside the heart. There are 4 chambers to the heart. The top chambers are the atria. The atria receive blood from the body. The right atrium receives blood from the superior and inferior vena cava. And that blood that the right atrium receives is oxygen poor blood coming from the body. The left atrium receives blood from the pulmonary veins. So the blood that's coming into the left atrium is oxygen rich blood that is coming from the lungs. The bottom 2 chambers are the ventricles. The job of the ventricles is to pump blood to various parts of the body. The right ventricle pumps blood into the pulmonary trunk and pulmonary arteries. It is pumping oxygen poor blood to the lungs. The left ventricle pumps blood into the aorta, and it is pumping oxygen rich blood to all parts of the body. The heart contains valves, which are flaps of tissue that prevent the backflow of blood. Circulation is a one-way circuit through the body, and the valves help to ensure that one-way directional flow. 2 of the valves are called atrioventricular valves, or AV valves. These are located between the atrium and ventricle on each side of the heart. The tricuspid valve is located on the right side of the heart. The bicuspid, also called the mitral valve, is located on the left side of the heart. These valves have chordae tendineae attached to them, and the chordae tendineae anchor the valves in place. Their ultimate job is to make sure that they don't end up flipping back into the atrium while the heart is pumping. So they basically prevent what would be like an umbrella inverting in the wind. The chordae tendineae prevent the valves from inverting. The AV valves will open and close in response to pressure. The AV valves are open when the ventricles are relaxing. That allows blood to go from the atria to the ventricles. And then the AV valves are closed when the ventricles are contracting. That ensures that when the ventricles contract, the blood continues on into the blood vessel that it's supposed to, rather than backflowing into the atria. The other two valves are the semilunar valves, or the SL valves. These are located between each ventricle and the receiving blood vessel for that ventricle. So the pulmonary valve is located on the right side of the heart. The aortic valve is located on the left side of the heart. And these two open and close in response to pressure. The semilunar valves will be open when the ventricles are contracting, because they need to make sure that they're open to let the blood flow into the correct blood vessel. These are closed when the ventricles are relaxing. When the ventricles are relaxing, that's when they're filling with blood from the atrium. And so we want to make sure that that blood isn't trickling out before the ventricle actually pumps it where it needs to go. The heart sounds that we can hear with the stethoscope are actually the closing of the heart valves. So the two sounds that we hear when we listen to the heart, the lub dub, the first sound, the lub, is when the AV valves close. So that's when the tricuspid and the bicuspid valves close. And this indicates the beginning of ventricular systole, or the beginning of ventricular contraction. The dub is when the SL valves close, the pulmonary and aortic valves, and this signals the beginning of ventricular diastole, or ventricular relaxation. Cardiac auscultation is listening to sounds at various parts of the thorax, and by doing that, specific valves can be heard when listening in specific locations. This requires practice and skill. There's very small differences in the sounds, the pitch, the timing of the valve closures. And so it takes time to figure out exactly what those sounds are. But if you go for a checkup and they move the stethoscope in probably 4 different locations on your chest, they're specifically trying to hear the 4 different heart valves. Now, when they listen with the stethoscope on your back, that has nothing to do with heart sounds. When they listen on your back, they're actually listening to sounds of your lungs when you're breathing. When there are abnormal heart sounds, that is referred to as a heart murmur. And there's a couple of reasons why we might have these abnormal heart sounds. One would be regurgitation, which means there's a backflow of blood. This could be caused by a valve prolapse, and this is when the valve is bulging upward into the atrium, or it could be a complete fail where the valve is not functioning at all. Murmurs could also be due to stenosis. Stenosis is when there's a narrowed valve opening, and that's usually due to stiffening of the cusps, or the flaps of the valve. If the murmur and if the malfunctioning of the valves is severe enough, then that might warrant a valve replacement. And in valve replacement surgery, the damaged valve is removed and it's replaced with some sort of alternate valve. It could be a mechanical prosthesis, which is a completely man made structure, or it could be replaced with a biological tissue valve, which could come from a human cadaver, a bovine source, which is from a cow, or a porcine source, which is from a pig. We find very little um, rejection rates when we're using cow or pig valves. The type of replacement that's decided upon is based on um, the seriousness of the problem, the doctor's preference, the patient's preference. So there's a lot that goes into the decision of what kind of valve will actually be used in the replacement. So the heart actually functions as a double pump, and that's because of the wall that separates the right and left sides of the heart, and that wall is called the septum. The septum completely separates the right and left sides, so there's no mixing of oxygen rich and oxygen poor blood. The oxygen poor blood always stays on the right side. The oxygen rich blood always stays on the left side. The pulmonary circulation loop is controlled by the right side of the heart. And this is when the right side, specifically the right ventricle, pumps oxygen poor blood to the lungs. The systemic loop is controlled by the left side of the heart. And this is when the left side, specifically the left ventricle, pumps oxygen rich blood to the body. One thing that you will need to know for our next test is the pathway of blood circulation through the heart as well as through the body. Keep in mind this is a circulation pathway, so there's really no starting or ending point. So you should be able to begin at any point within the heart or at any point within the body and go through all of the circulation and end up at the same place where you started. One way that makes this a little bit easier to study and to review is to have a diagram similar to this or a heart diagram in front of you and actually outline the process as you're going through the different steps. So, in addition to pulmonary and systemic circulation, there is also a pathway that's called coronary circulation. So, the heart, even though it's pumping blood throughout the body, the heart walls are too thick to survive on diffusion. So even though blood is going in and out of the heart needs its own way of getting its own blood supply and nutrients so it can stay alive. So the coronary circulation is the method which supplies the myocardium with blood. So there are two major coronary arteries that branch off the aorta. And so these branch and supply the heart with oxygen rich blood. Once that blood is used by the heart, there are three major coronary veins that empty right into the right atrium. And that's collecting that oxygen poor blood that's been used by the myocardium. Even though the heart is only about 1/200th of the body's weight, it requires 1/20th of the body's blood flow. So, because the heart is constantly functioning, it does not get a break, it needs a large supply of blood to be able to do its job. And of the two sides of the heart, the right versus the left side is going to get more blood flow than the right. And that has to do with the job of the right and the left side of the heart. The right side of the heart is pumping blood to the lungs, which are very, very close, where the left side has to pump with enough force to pump blood to all other parts of the body. So, since the left side has to do more work to pump blood to all those different locations, the left side is stronger and gets more blood supply. There's also collateral circulation pathways. These are networks of tiny blood vessels that usually don't transport very much blood. However, if the coronary arteries become narrowed and aren't transporting blood like they should, these collateral blood vessels can enlarge and become more active. This helps to prevent myocardial infarctions. That's just the medical term for heart attack. If those coronary arteries become blocked, that means heart muscle tissue is not going to get blood flow, and anything past the blockage, that heart tissue can die. And so these collateral pathways help to ensure that the heart is always able to get blood supply that it needs. If the coronary arteries are blocked, then oftentimes a coronary artery bypass graft surgery or a CABG surgery may need to be performed. This redirects blood around blocked coronary arteries. And to do this, it's going to use a healthy blood vessel from the leg, the arm, or the chest to reroute blood flow. How many reroutings that need to occur will help name what the CABG is. It could be a single, a double, a triple, or quadruple bypass. So now going from gross anatomy to microscopic anatomy, the heart is made of cardiac muscle cells. Cardiac muscle cells are short cells that branch. They'll usually have one nuclei. They might have two, especially if the cell is branching in two different directions. It might have a nucleus in each branch. Muscle cells of the heart have a large number of mitochondria. Remember, the heart can't rest or take a break, and so it needs a constant supply of energy, which is supplied by the mitochondria. The muscle cells are arranged into sarcomeres and are striated. So they have a similar structure to skeletal muscle, but cardiac muscle is involuntary. In between individual muscle cells are intercalated discs. These are connections that anchor branching cells together. And their main function is to allow for a fast passage of electrical messages. So the heart can get a signal, and through the intercalated discs, it can make sure that all of the heart muscle cells function in unison, so the heart behaves as a functional unit. The internal conduction system of the heart is what controls the heart rate and the timing of the contractions of the different chambers. The internal conduction system functions with autorhythmic cells. These are cells that have automaticity, meaning that they are self-excitable and they're able to generate electrical signals without brain stimulation. This will initiate the cardiac cycle and coordinate contraction of cells throughout the heart. So there's going to be certain points within the heart that will give signals, and then all the cells in that area will do the same thing. So each individual cell does not need to be stimulated by the nervous system. The sinoatrial node is the main pacemaker of the heart. On its own, the SA node, the inherent rate is 100 beats per minute. That's how fast the SA node wants the heart to beat. But when the heart is under neural control, the brain actually slows the sinoatrial node. So the average beats per minute is about 72 to 75 beats per minute. The SA node is going to send an impulse to the atrioventricular node, or the AV node. This is going to delay the impulse very slightly, approximately 0.1 second. The reason for that is it allows atrial contraction to fully complete before ventricle contraction begins. We want to make sure that the atrium has totally pumped all of its blood into the ventricle before the ventricle contracts to pass the blood into a blood vessel. If the ventricle would contract too early, it's not going to be filled and it's not going to efficiently pump blood. The atrioventricular bundles will receive the impulse from the AV node, and that actually is what transmits the impulse to the ventricles. And then finally, the Purkinje fibers conduct the impulse from the interventricular septum down to the apex and then up towards the ventricles. And so you can see how these different parts of the conduction system work in that animation off to the side. We can measure the electrical activity of the heart with electrocardiology, and this is recorded with an electrocardiogram. This can be abbreviated ECG or EKG. In a normal ECG, we would see a P wave. That is when the atria are contracting. We then would see a QRS complex. That would be when the ventricles are contracting. And we would then see a T wave. That would be the repolarization period when the heart is getting ready for the next cardiac cycle. By studying electrocardiology and the EKGs, one could identify arrhythmias that might be taking place. An arrhythmia is when the electrical impulses do not work properly. This could affect the atria, it could affect the ventricles, or it could affect both. Two common arrhythmias are tachycardia, and that is when there is a fast beat with the heart, greater than 100 beats per minute. Bradycardia is when there is slow contraction, slower than 60 beats per minute. By looking at different EKGs and seeing different patterns, doctors can actually determine specifically what is wrong with the heart based on the pattern that they see with the EKGs. Sometimes arrhythmias can be remedied with an artificial pacemaker, which can be implanted under the skin with electrodes that go into the heart, and that can then help the heart have a more regular beat or rhythm. Congestive heart failure is a very common heart problem, and it's also a very broad heart problem in terms of its description. Congestive heart failure is when there's damage to, weakening of, or stiffening of the heart. This results in the heart not being able to pump blood as it should. And there's different symptoms for right-sided heart failure versus left-sided heart failure. If the right side of the heart starts to fail, that means blood from the body is not being taken up back to the heart as much. And so oftentimes with right side heart failure, we're going to see swelling in the lower limbs of the body specifically. Left side heart failure means that blood is going to the left side, but the left side is not able to pump it out to the body. And oftentimes we see pulmonary congestion with left side heart failure, where blood is pooling in the lungs and the left side is unable to direct that where it needs to go. More specifically, you can see some of the symptoms with right-sided versus left-sided heart failure. They're going to have different symptoms. So now switching gears to the fetal heart and the development of the fetal heart, there are certain milestones that occurred during the 40 weeks of gestation. At about 5 weeks, that is the first time the heart begins to beat. But at 5 weeks, it is only a tube-like structure. At 6 to 7 weeks, it begins to fold on itself and starts to develop the 4 chambers of the heart that we're familiar with. At about 8 weeks, it is possible to possibly see and hear the heart in an ultrasound. By 9 weeks, the 4 chambers are fully formed. By 12 weeks, you may be able to hear the heart with a Doppler. And at 40 weeks or at birth, the lung bypasses should close. Here is showing the different developmental stages of the heart and the fetus at those different stages. So fetal circulation is a bit different than normal circulation. And that's because in a fetus, the lungs are non-functional. There's no reason for the lungs to be functioning because the placenta is responsible for all gas exchange. So there are 2 umbilical arteries. The umbilical arteries are going away from the fetus and they're carrying oxygen poor blood that the fetus has already used to the placenta. There's 1 umbilical vein which is going toward the fetus, and that's carrying oxygen-rich blood from the placenta to nourish the fetus and all of the fetal cells. So once the baby's born, the placenta, sometimes called the afterbirth, is also delivered. Usually the cord is cut. There is something called a lotus birth. This is not something that's very common, but it does happen, especially in other cultures, where instead of clamping and cutting the cord, it is left attached and it eventually dries up and detaches on its own after about 2 weeks. So now back to those fetal heart bypasses. These are sometimes called holes in the heart. So if you've heard of an infant being born with a hole in the heart, it's probably referring to one of the 2 fetal heart bypasses that have not fully closed. So as a fetus, these allow blood to bypass the non-functional lungs. So this is a method for blood to go through circulation without having to go to the lungs, which aren't doing anything anyway. These should close at or very soon after birth. And if they don't close, then there's going to be mixing of oxygen-rich and oxygen-poor blood. And that is going to compromise the circulation of the infant. One bypass is the foramen ovale. This is in the atrial septal wall. So it's between the right atrium and the left atrium. Because of the foramen ovale, oxygen-rich blood from the placenta can go from the right atrium to the left atrium to the left ventricle to the aorta. And once this closes, there's a scar remnant in between the atria that's called the fossa ovalis. The other bypass is called the ductus arteriosus. This is located between the pulmonary trunk and the aorta. This allows oxygen-rich blood to be able to go directly from the right atrium to the right ventricle, to the pulmonary trunk, and to the aorta. This, upon closure, will also leave a scar, and that scar is the ligamentum arteriosus. This is an animation showing circulation before birth and then circulation after birth. One developmental disorder is ectopia cordis, or an ectopic heart. This is when an infant's heart is either partially or totally outside of the thorax. And so this can be very dangerous. And then usually there needs to be some sort of surgery done to then re-enclose the heart into the chest. But it is possible for a baby to be born with the heart on the outside of the body. So going into age-related developmental aspects, as we age, there are higher incidences of myocardial infarctions or heart attacks, strokes, coronary heart disease, and heart failure. There's also changes to the electrical system, making it less efficient. So arrhythmias become more common. The valves tend to become thicker and stiffer, which is going to limit blood flow out of the heart. The valves could become leaky, have murmurs, and this could lead to edema, which would be a fluid buildup, and this could be in the lungs, the legs or feet, and the abdomen. And then there's enlarging and thickening of the heart walls. When this happens, it actually decreases the volume of the chambers. And so even though the heart is larger, it's actually able to hold less volume of blood. It also causes the heart to fill more slowly, and there's less cardiac output or less blood pumped with each beat of the heart. So the heart is going to be working harder to do the same amount of work that a normal sized heart could do. Finally, a disorder called broken heart syndrome. So this is stress-induced cardiomyopathy. So this is the result of a release of stress hormones that can cause reduced effectiveness of the pumping action of the heart, or it could cause the heart to contract too forcefully. The symptoms are extremely similar to a heart attack. So oftentimes, an individual who has broken heart syndrome actually will think they're having a heart attack. They'll have shortness of breath, they'll have chest pain, but upon examination, they have no blocked arteries. And so, even though this is not a heart attack, it still can result in heart failure and death because it's putting extra stress on the heart.